So today we'll be presenting Integrating Public Health and Primary Care, New York City's Regional Extension Center's best practices. I am Sheila Anani, and here today I also have with me Rachel Helfont and Ann Rappin, and we come from the New York City Department of Health, and our organization has a bureau called Primary Care Information Project, and we are also the New York City Regional Extension Center. In today's session, you will learn about our activities and what we've done to leverage EHR data to help providers with quality improvement. We'll describe our success factors and lessons learned with our work and identify potential services to incorporate our future rec activities towards sustainability in the use of EHRs and working with providers on quality improvement. For our agenda, we've broken it up into 3 different sections, one in which we'll cover a history of our quality improvement activities, our current regional extension services, and a case study that we are currently doing with a partner who is a Medicaid managed care plan. So thinking of the New York City Department of Health, we in our role often refer to ourselves as a virtually integrated network. We aspire to be like the large integrated systems such as Kaiser and Geisinger, and have worked with providers across the city to create a virtually integrated network. Through our work as the Primary Care Information Project, founded in 2005 as a mayoral initiative, we plan to improve the quality of care through the implementation and use of health information technology. And in that work, we have helped over 3,000 providers implement software. In 2010, our organization also became a regional extension center and expanded our implementation work with other electronic health record vendors, and as a result have recruited over 9,000 providers who are receiving health information technology assistance. And that would include small practices, community health centers, as well as hospital ambulatory clinics. So what you see here on this slide is a map of New York City and the 5 boroughs. We have penetration across New York City, and when we originally started, we also reached out to providers in underserved areas. So what you can see here is that we cover much of this city and are pretty diverse with the providers that we work with. On this slide here, you can see the public health functions. One advantage to being as part of the health department is we've originally have had to incorporate this work or this idea of public health into primary care. And this is a way that we have illustrated that. The 3 public health functions would be assessment, assurance, and policy development. And how we've identified or shaped our work has been through data, quality improvement, and policy dissemination. So for the assessment piece, collecting data, helping our providers adopt an electronic health record, and create a system in which data is transmitted to us. And then with the assurance, taking that data and creating quality improvement programs, doing data analysis, helping providers understand how to use their electronic health records to document in a meaningful way using the meaningful use standards. And we've also developed a feedback report to help with that process of looking at the data and sharing that information back with providers. For policy development, we've done some policy and dissemination by doing research projects, creating programs where we evaluate our work, publish information, and as well as commenting on national programs. in addition, we've also partnered with different community groups to share our lessons learned. So taking those 3 principles for public health and how we interpret them in our work, this is a diagram of how we're structured at the primary care information process. We have various types of data. One we've mentioned is electronic health record data. We also receive A1C data, claims data, regional extension, or real information, and meaningful use data from our practices. With quality improvement, we have a team of quality improvement specialists who work in the field with providers, helping them understand how to use their record, how to measure their performance, and how to implement workflows to help them improve. And I talked just briefly about how we've been able to do that through the use of dashboards and training. And we also have included, more recently, additional partners such as accountable care organizations and payers in our work. So coming from the health department and setting an agenda for what would guide our work, we used some of this information presented on this slide. Looking at the public health causes and trying to identify where to start, we wanted to pick things that would affect most New Yorkers. And that you can see here on this graph, the top conditions that are leading causes of death in New York City in 2008. There's heart disease and lung cancer and diabetes and cerebrovascular disease. And those are all conditions that could be avoided through the control of the ABCS measures, antithrombotic use, control of high blood pressure, cholesterol control, smoking, and obesity. So we've used this to guide our work. And what you see here on this slide is the prevention focus that we've applied. Dr. Farley, Dr. Mastashari, and Dr. Frieden worked on an analysis of preventative services. The y-axis shows the number of preventable deaths in the United States, and the x-axis shows the percent of control. So in this example, looking at hypertension control, if you are performing at 50%, that would prevent 20,000 deaths in the United States. But if you could offer additional preventative services where up to 80% of your patients had their high blood pressure controlled, that would result in about preventing 43,000 deaths nationwide. So looking at this slide and looking at the top leading causes of death, this has helped shape some of our work around the ABCS measures in rolling out programs and offering technical assistance to our providers. So looking at the synergy with Million Hearts in our work as the New York City Health Department, we've placed this information on a slide to see the areas of overlap. As part of 2004, the New York City Health Department created a program called Take Care New York, where the goal was to improve the health of all New York City residents. And they've come up with 10 priority areas. So as the Primary Care Information Project, we then interpreted those 10 priority areas and created clinical quality measures so that we could understand how our providers are performing across the practices we work with and create programs to help them improve. So for keeping your heart healthy, we have created the measures for aspirin therapy, blood pressure control, and cholesterol control. And those are the same measures that are also included as part of Million Hearts. So this work has been something that we've done for some time, and in this presentation I'll cover some of the specific projects around these specific measures. One of the things that we also interpret or incorporate into our work outside of the public health functions would be data information, action, and dissemination. So beyond just collecting data and analyzing it, we wanted to inform others about the data so that they could use that information to create change and to also share their findings with other individuals. I mentioned briefly in the beginning of our work, we worked primarily with one vendor and really worked with them to develop a prevention-oriented electronic health record that was specific to the Take Care New York initiative. But since then, we've extended our work working with other vendors as a regional extension center and have incorporated other clinical areas and also different partners. So I had mentioned the provider dashboards and how this tool is used. This is a tool that we use throughout the department to share the data that is sent to us, to our providers, so they know exactly where they are and identify areas for improvement. So just showing this dashboard, there's 5 different sections. The left section shows a legend, an area for recommendations, and the recommendations are tailored to the data that is on the specific dashboard and changes based on the data that is there. There's syndromic surveillance information that covers gastro illnesses and as well as influenza-like illnesses. Some CPT code information on the bottom left corner to help providers look at the variability of their coding for new and established office visits. The middle section would be utilization measures, and then the far right would be quality measures, 10 different quality measures, and below that an image displaying the practice's payer mix. So this section is highlighting the quality measures. And just to be a little bit more clear about how it's read, this report was meant to be designed to be an at-a-glance report, where by looking at it, you can see the color coding of where you need to perform or continue to perform at a higher rate, or where you fell below the community average. So the red dot in this first example would be for A1C testing, and that is for the last month. That provider performed at 46%. The community average, which is the average of PCIP providers, happen to be performing at 50%, and that's where you see that gray fine line below. The spark line is a trend over the last 6 months, and it's red in this instance because this provider happened to be performing lower than the community average. Providers can then also click on the name of the measure and link to a wiki resource which would display step-by-step directions on how this measure is satisfied in their EHR. So these provider dashboards have been a very helpful tool. Initially, it's been helpful for providers to understand our role, what we're looking at, and how we can help them improve, and also in sharing with them information that they usually don't receive, and that would be the community benchmark. On this slide, I have 3 measures, the BCS measures that show providers who were performing at a higher performance level or a lower performance level based on before their first receipt of the dashboard. On each of the graphs, you could see a green line, which would indicate the start of the dashboard receipt and their performance over time. Practices who were below benchmark or average at the first time of the dashboard were able to make considerable improvements. We think a lot of these improvements are not only limited to the dashboard, but also to the technical assistance that we provided these practices, in addition to sharing this information to them. One thing that is also noted is, even though the practices who were performing below average did not meet or in some cases exceed the higher performing practices, they were able to make considerable gains at a faster rate than some of the high performing practices. So when considering certain tools that can be deployed and scaled to a number of providers, a dashboard could be quite effective. So now moving on to discuss some of the programs that we've implemented around the ABCS measures. One that we have here is Healthy Hearts. This is a pay-for-quality initiative that was implemented in 2009 and was funded by the Robin Hood Foundation. Again, focusing and trying to narrow in on the top leading causes of death and quality improvement activities that would prevent those deaths from happening, we looked and focused on the ABCS measures. Small practices and community health centers were recruited and placed in a controller incentive group. They received technical assistance and quarterly dashboards on the ABCS measures. In the graph below, what you see are the different ABCS measures. The y-axis is the percent of patients with that preventative service, and the y-axis is the different measures. So just looking at taking aspirin therapy into consideration, looking at the control and incentive groups, both groups were able to make improvements, whether they were in the control group or an incentive group. And that was one of our takeaways from this initiative. By working with providers, giving them technical assistance, and having them look at their data and make changes at their practice to either offer more preventative services, they were able to make improvements with or without financial incentives. Another takeaway from this project is the importance of recognition to providers. We hosted a recognition event for practices with the most improvement, and in the picture below you see our commissioner posing or taking pictures with some of these providers, and they also received a plaque. Providers were very excited to be recognized and to meet the commissioner, and this is something that is also could be implemented across other projects. If there's a limited budget and providers cannot be incentivized, the ability to recognize providers for their good work and to give them something that they could then display in their office is quite impactful. Another initiative that we implemented was Healthy Quits. This particular pay-for-performance initiative focused on smoking. We did notice that smoking was very hard for our practices to complete. A lot of it was a documentation struggle from moving from documenting it however you would like in the electronic health record to a more structured format. So here on the top graph, you see the 19 different community health centers that we had worked with and their rates of improvement. So just looking at practice 16, their offering of smoking intervention services at baseline was 51%. And over the course of this project, they were able to increase their offering of tobacco cessation interventions to 58%. Looking at the graph below, this shows the group as an average and then those who performed at the 90th percentile over time. These group of practices were able to increase their interventions from 27% to 52.8% over the course of the project. And we've learned a lot of lessons here, because not only did providers need to work on how they document smoking as a structured process at their practice, but also they needed to work on how they would document either counseling or the offering of smoking cessation medications, or to make referrals to community resources such as Facts to Quit line, where the patient is then contacted afterwards and offered free or subsidized materials on smoking. As part of PCIP, we've also assisted our providers with patient-centered medical home applications. Here we've taken some measures and tried to show the difference between practices who are currently PCMH certified and those who are not. And we've noted that some of the practice, or in some measures, practices who will have PCMH certification perform at a higher level. And one thing to take note of here is the practices that we helped with PCMH received a lot of technical assistance. So in working with them to complete the application, they again learned how to document in a more structured fashion, were able to look at their measures over time, and also make modifications in their workflow to either document better and also to identify patients who are in need of follow-up for preventative services. From those lessons learned and from talking to our providers, many of them noted that they just don't have the additional time or resources to do more preventative services. So we then created a pilot, which we then scaled to a full research project funded by Pfizer, where we wanted to focus on gaps of care and create a shared resource model where small practices could have a prevention outreach specialist visit their practice on a weekly basis, run a registry report to identify patients with gaps in care, and call them for follow-up appointments. This is a project we completed from 2010 to 2012, and there was a focus as well on the ABCS measures. Over 20,000 patients were called, 66% of them were successfully contacted, and of those who were called, over 2,400 scheduled appointments for follow-up visits. The evaluation is a process that's still ongoing and will soon be completed towards the end of this year. In talking to the providers who had a prevention outreach specialist, they informed us that they loved having someone at their practice, and talked about the struggle of them not being able to do this regularly by themselves or with the staff that they currently have in place. So looking beyond pay for quality improvement, PCMH assistance, and panel management, we've also looked outside of that and tried to connect our practices with community partners. As part of our work, we also have a Keep on Track program where we teach community workers how to measure blood pressure and offer them supplies so that they can use these resources with those that they work with. Taking those lessons, we worked with 8 New York City churches to give them a web tool so they can track blood pressures. In the Keep on Track program, the blood pressures are tracked on an index card. And in a focus group where we asked them how to improve that project, they would mention that after a patient had a high blood pressure and it was tracked on a card, you had a hard time identifying who that person was in future and when to follow up with them at a later date. So this tool allows them to find that person and to also look across their church congregation to see what is their blood pressure as a group. How many people have high blood pressure? How many people do not have high blood pressure? And then use that to also create programs. We've also convened a South Bronx Community Referral Task Force to better understand how small practices want to refer to community resources. One community resource that we've highlighted for our practices is the YMCA's Diabetes Prevention Program. And through that initiative, providers would identify patients who are pre-diabetic, inform their patients, and inform the Y about these patients to see if they would be eligible and willing to come to a 16-week course to teach them about lifestyle modification. So one of our newer initiatives looking at quality improvement is how could we do this in a faster way, if possible. We were invited to participate as part of a Beacon Challenge, which is a 16-week initiative to improve cholesterol screening among diabetic patients. And in that ask, we created a weekly dashboard to share with providers how they're doing and also to highlight opportunities for care because these are patients with upcoming appointments. So in looking at this dashboard in a bit more detail, what you see here are the days of the week, patients who have appointments in the upcoming week, and it really highlights on those who need follow-up. So not only does it tell you the percent of patients who are diabetic in this week, it also tells you of those patients who are diabetic, in this case 8 on Monday, 7 of them do not have a lipid test ordered. If they did have a lipid test ordered and their LDL was not in control, it would be in that next group of patients. For Tuesday, you see that it says LDL greater than or equal to 100. They happen to be 5 patients. And of those 5 patients, 1 patient is not on a statin, and that would be the recommended treatment for cholesterol control. So in this report, it is prospective, and it highlights opportunities for care in addition to showing them their performance. Another section to highlight on this dashboard is last week. We compare the practices, ordering and prescription habits for the last week by saying, for the opportunities that you had, how many were completed and then how many were missed. And I think this is different because when you show providers monthly trends, they usually sometimes are flat if providers are not specifically focused on an area and try to work on improvement. And it's easy to not see the opportunities that were missed. By highlighting it very specifically in this last week section, it is definitely more specific and apparent to providers, either a subset of patients that they should recall to come back into the office, or it makes it apparent how many opportunities they could have closed but may have missed due to other challenges in the practice. And taking the lessons that we learned from panel management, that's how we, and our current dashboard, we created this to see our providers' feedback. This process is ongoing, and we should have a summary of provider feedback and improvement early October. So overall, just to highlight our work on the ABCS measures, we've had a variety of different experiences with quality improvement in ABCS. We've done pay-for-performance initiatives, helped providers with application processes, offered assistance as an extension to the actual practice through panel management, and have utilized the tools of dashboards to share their progress with them. And as a result, it has resulted in noted improvements. So in this example, we have a limited group of practices, 150 practices, who had been using the EHR from 2009, and we would consider these practices early adopters. And in working with this group, providers delivered 3 times the number of recommended preventative services over time, which resulted in improved diabetes management for 81,000 patients, improved blood pressure for 96,000 patients, and access to smoking cessation programs for 58,000 smokers. In addition to the improvements, we do note that it's not only the electronic health record. It has been the work of our quality improvement specialists working with our providers and offering technical assistance. In this graph here, it shows the percentage points for quality measure and the months of exposure to the program. So just being a part of the program, although helpful, is not as impactful as being in the program and receiving technical assistance. So providers who receive technical assistance over time perform at higher levels than those who have not. So in summary, taking some of the things that we've talked about, some of the system-wide processes that integrated delivery systems implement can be applied in independent small practice settings. Feedback report and technical assistance are essential in quality improvement. And one thing that is noteworthy is financial incentives alone are not enough to improve quality improvement. So we'll now transition to Rachel Helfant, who will be talking about our NYC REACH services.
Okay, thanks, Sheila. So for this section, I'm going to go through some of what we've been doing as the Regional Extension Center for New York City and discuss some of what we're thinking about for the future to make the Extension Center sustainable, given some of the trends that we're seeing in the state in healthcare and in health information technology. So first, I'll just give some background on NYC REACH, which is the Regional Extension Center, as I said, for New York City, and it was established by PCIP. So it's the same group that had been doing a lot of these projects that Sheila talked about, then set up the Extension Center. And we really see it as the way that we can take all of those lessons learned from all those different projects and the studies that we've done and really deploy them out into far more doctors across the city. So we have a pretty large target of about 4,100 priority primary care providers that we're trying to get to meaningful use, and these are all located within the 5 boroughs of New York City. So we use mostly a direct service model where it's actually NYC REACH staff that's going out into the practices and working with the doctors directly. So we have a very limited use of subcontractors. Mostly it's our folks that are hopping on subways, getting on the bus, and going out to the boroughs to talk to the doctors. In addition, we have about several thousand extra doctors that have been enrolled in the program because we have additional state funding for Medicaid specialists and behavioral health providers. So that allows us to work with a lot more than just primary care providers. So in sum, we have about 2,000 of the primary care providers that have already gotten to meaningful use, and that's most of what we're focused on right now. So this is just a little bit about our membership base. It's relatively mixed across settings. So if you look at the provider mix chart, you can see that it's relatively evenly split between hospital outpatient departments, community health centers, and small practices. But then if you look at the actual practice types, you see that it's heavily weighted towards small practices. So most of the individual practices that we work with are, one doctor, solo practitioner, maybe a couple doctors in a practice, but they typically do not have a lot of administrative infrastructure, so they really rely on us to come in and help them navigate a lot of these programs. The other thing that makes our program, I think, kind of interesting is that we're heavily weighted toward Medicaid. So if you look at the graph of meaningful use program registration, you can see that most of the doctors in our program are going for the Medicaid Meaningful Use program, and that has the minimum threshold of 30% Medicaid patients, although I would say that most of the doctors in our program that are going for Medicaid see far more than 30%. I mean, it's 80, 90, 95%, sometimes 100% Medicaid patients, and that just has to do with the population of who we have here in New York City. So for NYC REACH as an extension center, if you think of kind of our typical practice, it's a single doctor in Chinatown with 80% Medicaid patients. Maybe it's a small group practice in the South Bronx that sees somewhere like 75% Medicaid patients, but that's kind of the flavor of who the doctors are that we're working with. And so over time, you can see that meaningful use is picking up speed, specifically this year. Because so many of them, of the doctors are going for the Medicaid program, they had to wait until late 2012 for the New York State Medicaid attestation system to actually open. Prior to that time, it was only our Medicare doctors who could go in and attest. But once we saw that open, obviously a lot more doctors were eager to meet all of the measures and apply for their incentives. So we've seen huge jumps for meaningful use. So that's good for us as a regional extension center, but it also, as we're looking toward the future, it helps us understand kind of who the foundation is that we're working with. So we really see the 2,000 doctors that we now have at meaningful use as the true foundation for future work. So other quality improvement work that we'd want to do, other kinds of measurements, is going to be all that much stronger because now we have these thousands of doctors that are at meaningful use, and we are planning to double this before the grant ends in early spring 2014. So looking forward then of how we're going to build on this program, we see the same trends that drive healthcare discussions really nationwide. So on the one hand, you have all of these doctors who are using their electronic health records, and because of that, they have improved data capture and improved abilities to report on their quality measures. Simultaneously, you have a lot of different programs looking to save money. So we keep talking about healthcare costs and how we're going to address those problems. So when you combine these two trends, what you really see are a lot of pay for quality and a lot of shared savings programs. So some of the things that we've been experimenting with seem to be going a lot more mainstream, and we expect that this is going to be the future, and this is what the doctors are going to have to adjust to and learn to manage. And here in New York City, we really see an environment of cost savings. They've been significant already. Starting in 2011, New York State Medicaid implemented a Medicaid redesign program, and since then they've actually been able to bend the cost curve, and if you look at the red dotted line, that was what they had projected their spending to be. The black line is what they actually have been spending. So the difference between that is an estimated $3.2 billion in savings. And I'll mention that this is all while the actual number of Medicaid recipients has gone up. So they're spending significantly fewer dollars per Medicaid patient. But what that means for us is that that $3.2 billion saved means it's less revenue for Medicaid patients. So this is all information that was shared by New York State Medicaid, so a separate program from us, but one that we work with closely. In July of 2013, so just a month ago now, they shared this data, and they recognized that savings, it comes at a price of the revenue for the doctors. And again, these are, the single doctor practice in Chinatown. Maybe it's a safety net community health center that only serves Medicaid patients. These are practices that, rely on Medicaid for a big chunk or all of their revenue. So when the state presented this data publicly, they also said that they wanted to figure out ways that they can share some of this savings back to the safety net providers and back to the providers that are taking care of the Medicaid patients. So they put a couple different options out there of things that they're now exploring, including a global shared savings program where the state through Medicaid would give direct payments back to providers through shared savings, or potentially a pay for performance or pay for quality program linked to different performance measures, or perhaps they would work with managed care organizations to develop individual shared savings plans. So we have about a dozen or so Medicaid managed care organizations in New York City that administer Medicaid for their patients. And in that case, each of them would have their own kind of shared savings program that they could experiment with. So this is the environment that we're seeing the state talk about, and as we're thinking about the future of NYC REACH and the future of how we're working with our doctors, these are the things that we're thinking about. And we actually have good reason to believe that these programs will come into place. In New York State, there's already a pretty generous patient-centered medical home incentive program, and this is a bonus with the incentives that you see here on the slide. So because of this, it's not uncommon for our doctors to receive an additional $21,000 per month for patient-centered medical home recognition. A lot of our doctors see at least 1,000 Medicaid patients on their panel, and you can see if they have level 3, that's an extra $21.25 per member per month. So this adds significant revenue to our Medicaid providers, and it's something that we see the state already experimenting with. So they've had this program in place for a couple of years, and then they've been evaluating it as they go. So one of the changes that they've made is they used to have incentives also for level 1 recognition for patient-centered medical home, and they've removed that because they weren't seeing the results that they needed. So these are the kinds of programs that we've already seen in New York, and we just expect them to expand. And so for us as an extension center, we're trying to think about how do we fit in and how can we make sure that as these programs go on, important public health measures like those that, like the Million Hearts measures, like the ABCs, that they're being incorporated as well. So our vision for NYC REACH looking forward and looking toward the end of our 4-year grant and toward later stages for meaningful use, these are 3 of the points that we are trying to make sure we maintain. One is that we want to continue to offer affordable assistance to the doctors as these new challenges arise. So we see health information exchange coming, and there's a lot of changes that will happen with their workflows, with new technology being implemented, and we want to be in a position to help them navigate that. New payment models, so like I said, the state has indicated that they are exploring shared savings and pay for quality models, and we want to make sure that we can help translate that to the doctors and help them change their practices so that they can take advantage of those payment models and not just see their revenue drop across the board. And then the third one is that there will be additional reporting requirements, sometimes with incentives attached to them, sometimes with penalties attached to them. But what we find is that a lot of the providers that we work with, especially those in small practices, can have trouble understanding what these requirements are, can have trouble navigating some of the administrative side of it. And so we want to make sure that we are, remain here as a resource when they have these questions. And if that's way, they can always pick up the phone and they can call us, and we can be a resource for them. The second goal that we have as we look to the future is to maintain these public health or these provider relationships. So Sheila mentioned, PCIP has a lot of different grants that we get in, a lot of different pilot programs. We try to be very innovative and try to, try out new tools and test new methods for improving public health. And the way that we can continue to do this is by continuing to have these relationships with doctors across New York City, so that if we're trying a new blood pressure program or if we're trying a new smoking program, we have this member pool that we can set up these pilots with. And then the third one is to work with local stakeholders to align the quality improvement programs and potentially fund our future work. So we have a lot of different partners that we work with who are also trying to do quality improvement, and our goal is to make sure that as they're looking at quality improvement, they're picking the measures that matter most, and that we can help work with the doctors to prioritize these measures and really help them understand how they all work together. So just to give a little bit more of an explanation of where we're looking to go as an extension center in our sustainability is we are now already offering post-meaningful use services to the doctors. These are things that they can pay for if they find that it's useful for their practice, and this really speaks to that first point of continuing to offer affordable health IT assistance. So even if it's not fully subsidized, it's well worth it to the physicians to be going for patient-centered medical home, to learn how to use their EHR, to bill and code correctly, to customize their EHR so it's easier to use. So we've already put some structures in place to continue to be that resource. And then as far as working with these partners, as an extension center, we've worked with everyone in the community with an interest in health information technology really since before we even got the grant. It was a way that we would recruit new providers into the program, and it's the way that we would get the word out about meaningful use. But looking toward future sustainability, we've prioritized a few of these groups based on our shared long-term goals around improving quality outcomes and aligned incentives around similar measures. So just to call out a couple on here, ACOs, or Accountable Care Organizations. These are Medicare shared savings organizations that they need to demonstrate quality. They're also being tasked with demonstrating meaningful use, so there's obvious alignment there. So we've been working with them to see how we can be most helpful. And then, of course, on the payer side, for New York Medicaid, and specifically for the managed care plans, the state judges them on their quality outcomes of the providers in their networks. So we've been working with several of them to leverage our staff who has clinical knowledge, who has IT knowledge, who knows how to do quality improvement, to work with their provider networks and make sure that they are able to achieve those quality goals. So we think that our staff here as an extension center is well positioned to help the doctors navigate all of these initiatives, and that we can also work with these partners to help them think through what their goals are and ideally align them all together. So when we talk about aligning quality improvement, a lot of these measures show up across the board for all these different programs. So Sheila mentioned before, for New York City, we have a Take Care New York policy program that prioritizes the ABC's heart health measures. For meaningful use, they also need to be recording and documenting for these measures and reporting on these clinical quality measures. Medicare ACOs I mentioned, they also are graded on very similar quality measures, if not exactly the same defined ones. And then for New York Medicaid, they use the national HEDIS measures as well as New York specific reporting program called QARR. And these, again, all have very similar measures. So as we're looking, again, to the future, we're trying to find those areas of alignment, and this way we can just talk to the doctor about blood pressure control and have them meet the requirements for all of these different programs. Now, at this point, it's not perfect yet in that not all the measurements are exactly the same. Some of them are reported differently, some of them are pulled differently, some of them look at slightly different populations. But what we find is that they're similar enough that we can work with the doctors to change their workflows, to set up their EHRs correctly, and they will improve across the board. So, for example, if we look at the smoking measures, for Take Care New York, what we're looking for and what we share back to the doctors is really around smoking cessation, things like how many of their patients who smoke did they do a counseling session with, and then we report how many they did and how they're compared to their peers. For meaningful use, what they're required to do is just document the tobacco assessment or the smoking status. So it's more about the documentation rather than the outcomes. For New York Medicaid, the way that they track the advising smokers to quit measure is by actually surveying the patients themselves. So they'll call up the patients or ask them to fill out a form and say, did your doctor talk to you about smoking? So all of these three measures, even though they're very similar, they're reported in different ways. But again, we feel that if our staff is training the doctors on how to incorporate smoking cessation services into their workflow, how to document it correctly, how to set up their EHR correctly, they will improve across the board for all of these programs. So because we feel strongly that all of these different programs are aligned, it's been in our interest to try and strengthen our relationships with these priority partners, such as the Accountable Care Organizations and the health plans. So one tool that we use to do that are these partner reports. And these reports are ones that we use to give them baseline information about how their network or their groups or their members of providers are doing. So what we do is whatever partner it is that we're working with will give us a list of all of the providers in their program. So if it's the health plan, it might be their entire provider network. If it's an ACO, it's their members. And we do an analysis and identify the overlap between that group of providers and the NYC REACH members. And then we do some analysis on what's going on with those doctors. So we look at what electronic health records they're using, how many are still not on an electronic health record, how are they doing toward meaningful use, how are they doing toward patient-centered medical home, and try to identify any areas that we can work together to meet those goals. So it really helps us kind of understand things like, do we need to do an educational session for their group about EHR adoption if there's a lot that are still using paper? Or if a lot have registered for meaningful use but haven't attested yet, we can start to dig into what measures are they most struggling with. The next phase of this is that we're starting to do aggregate reports, not just on how they're doing toward these milestones, but actually looking at aggregate quality measures across these different practices. So at this point, we're very sensitive to data sharing, and we don't share provider-specific or practice-specific information, but we more let them see what the community looks like as a whole. So this tool, as I said, is really an engagement tool, and it's a way for us to start the conversation with these different partners and really start just like our working relationship together so that they can understand what value we can bring to them. And then once we've started that conversation, we really start to put the strategy together around how we can work together to achieve our mutual goals. So we build on some Extension Center funded outreach work, which might include things like dinner presentations, joint fax blasts, email blasts, newsletter articles, or site visits where we'll send our staff out and talk to their doctors about meaningful use or help them on the specific measures and then report back to them of how they're progressing. And then we use that as a foundation to expand on to work beyond just the traditional meaningful use or regional extension center funded work. And this is where we start to get into some of the sustainability planning that also speaks to, keeping these public health measures in focus. So it might be things like doing paid patient-centered medical home training, or it might be doing things like targeted quality improvement interventions on the ABC's measures. So this might be a case where a health plan sees their practices really struggling with cholesterol control and will target a 6-month pilot or a short pilot to talk to their low-performing practices and help them improve on those measures. And we'll talk more in detail about what exactly that program looks like and how it would work. So before we get to that, just a couple quick lessons learned. So the first is that we find relationship management is a full-time job. So we have people dedicated on staff to working with these partners, to understanding what their needs are, to making sure that we're pushing these partnerships forward. And we find that keeping up with the other state and federal initiatives is really important to really understand their needs. So it took us some time to dig into, how do state Medicaid plans get judged and how can we help them improve on their scores there. And then the final point is really to be able to demonstrate your past successes quantitatively and use that as a stepping stone to be able to engage these other organizations. So some of the projects that we spoke about earlier, we've published studies on them. We had one just this year in 2013 in Health Affairs, and we're able to take that documentation and leverage it in a research brief or in a newsletter article or on our website so that when we're talking to ACOs and when we're talking to health plans, we can prove that our staff and our regional extension center is really going to be a great partner for them to help them achieve these goals in the future. So with that, I'm going to turn it over to Ann Rappin, who's actually a project manager on one of these programs where we're working with the health plan to help them improve the quality among their network providers.
Thanks, Rachel, and thanks for joining us, everyone. As Rachel mentioned, I'm a project manager, and I'm very much the boots on the ground for our field staff, as part of our field staff. And so throughout the rest of the presentation, I'm going to try to share the provider perspective that we hear for those of you who don't have the pleasure of working right with the providers. So to give you some background, getting our partnership set up with a health plan was a long haul. We started probably a year and a half ago, where the health plan was attending some of the seminars that we were giving to our providers around the city. And the health plan eventually approached us because they were interested in the data that we have. It was information that they didn't have on their own providers that they were curious about. Because of our arrangements, we don't share provider data with anyone. So we had to direct those conversations more to what services we might be able to offer the health plan and what they were actually looking for. So as we started to figure out what outcomes they were hoping for, we were able to draw up a proposal. Once we got that proposal on the table, though, things did speed up with the partnership, and probably 2 to 3 months after we initially offered them a proposal, we actually started working on our partnership. So what our partnership is a 6-month pilot project. Our main goal is to improve the QARR and HEDIS measures at 6 different pilot sites. So we have 4 small practices and 2 large practices that we're working with. The practices were selected sort of through a process where the health plan gave us a list of practices that they have, they're interested in improving the QARR scores at, based on the number of members on the panels there, as well as those practices being generally performing less or lower than the state average on those measures. And we crossed that list with our NYC REACH members and came up with the 6 practices that we'd work with. And so the measures that we're focused on are blood pressure, BMI, smoking cessation, cholesterol, and asthma. In total, we're working with about 50 providers, and that represents over 10,000 patients. So those are over 10,000 health plan members across those 50 providers. There are some additional goals of the pilot. We are working with the late EHR adopters and trying to get them off of paper and onto EHRs, so helping them navigate that process. We are working with lots of providers on meaningful use, so that fits right in line with our Regional Extension Center goals. And we're working on best billing practices with them as well. So QARR is the Quality Assurance Reporting Requirements. These are measures that are reported to New York Medicaid. They're based on the national HEDIS measures. They are reported on an annual basis, and they change slightly from year to year. And basically the data is coming from claims that are billed, they're coming from consumer surveys, they're coming from chart reviews, and a little bit comes also from pharmacy data. So when we were out in the field, we started talking to the doctors about this QARR reporting, and we were sort of astonished to find out that they hadn't heard of it before. A lot of them had no idea what it was. And so here we are making a big fuss about their QARR scores needing to come up, and it turns out that they weren't even aware of it, which was a little bit frustrating for them. So we explained that this is what the state, this is the information that gets reported to the state, which the state then uses to evaluate the health plan, and the health plan is evaluating the providers in turn. And so the thing that they were most frustrated about was to find out that some of the measures have incentive money tied to them. And so they were not aware that they were, being evaluated, and then they also had no idea on the things that they were being evaluated on. So we started by calling up all the practices and asking them if they were interested in participating in this pilot, and we told them a little bit about what would be happening. And as they agreed, we set up kickoff meetings. So at the kickoff meetings, some of these took place in the small practices right in exam rooms. So we had leadership from the practice, we had our executive director, I was there, we had a clinical quality specialist who's spent a lot of time in the field working with the practices, we had a billing specialist, we had a representative from the health plan. So you can imagine that was kind of a cozy discussion about the QARR measures. We also talked about our meaningful use services and how we can help them with billing. And we talked about how we very often look at the workflow in a practice and how we make adjustments that way. We talked about QIP dashboards, which stands for Quality, QU is Quality, and then IP is Improvement Partnership, these are dashboards that we arranged for this pilot, and we'll go into that in a little bit. And we also talked about sharing their data with the health plans, and that's something that was made optional for this project. If a practice decided that they wanted to share data, there was an addendum to their Regional Extension Center agreement that they could sign. So from there, we scheduled our upcoming quality improvement visits and our billing visits. And what we found when we went out for our initial quality improvement visits was that there's a whole lot of work that needs to happen at the practices before we can actually focus on the advanced quality improvement things. So we sort of had to turn our initial quality improvement visits into assessment visits so that we could bring everyone up to speed and get everyone sort of on the same page about what they should be doing. So we essentially came up with a checklist that all of the practices should be able to do before we could work on the quality improvement stuff. And in some cases, it was as simple as, what is structured data and why is it important to use it? So we had to go through those things. We had to make sure that there's a CDS alert turned on in their system and that they know what that is and how to use that. It was things like that. That they can run patient registry lists and know that their system has that capability. So we collected this information. We also talked to them about what their needs and interests were in terms of quality, in terms of disease focuses that they wanted to work on and within their community. And we learned about their workflow so that we could make changes if they might have been needed about who does what in the office. And from there, we started moving into more QARR and meaningful use related visits. At a typical visit, we'll talk about the QARR topics, so we'll go over all of the measures we're trying to meet. We'll do a system checkup, so we'll go through and see how things are configured to make sure that that's all in line, so that not only is the doctor doing the right things, but also their system is working for them and not against them. We'd go over their QIP dashboard. We'll talk about their meaningful use data. We'll talk about the clinical relevance behind these measures, both the QARR and the meaningful use measures. We answer their questions and deal with their problems. We give them a recap so they know what they're going to be doing before our next visit. And visits are generally about a month apart. Billing visits are also scheduled, and here we have our billing experts go out and meet with generally the billing staff at the practice. They're talking about, they're going through each measure also from a billing perspective. They talk about streamlining the billing processes, they handle questions, and they inform the practices about other incentive programs that are going on that they could be eligible for. So now here is the quality improvement partnership dashboard that I've been talking about. The QARR measures, as I mentioned earlier, are they're generally an annual measurement. We didn't want to wait that long to offer feedback to our providers. So instead, we started using something called the Take Care New York measures as a proxy. The measures are not exactly the same as the QARR measures, but they're close. So we're using that to gauge how the providers are doing. We're able to produce these dashboards with about a 2 to 3 week lag. So generally, after the close of 1 month, we start working on the dashboards so that we can give them to the providers as we meet with them the following month. And that allows them to see that the changes they've made are impacting their spark lines on these dashboards. So here's just a blow up so you can see a little closer what's going on in this dashboard. Along the left-hand side, we can customize it and include information about incentives that might be available or anything that we really want to communicate with the practice. We can also show them information such as what their total office visits were for the past few months. We can show them what their billing was, their billing visits, visit codes were for their visits in the past month. We can put in different bits of information like that. In the center, we have these spark lines that show how the provider has been performing over the past 6 months. And we also have a dashed line that is showing how all of the other providers who are participating in this pilot are doing over the same time period. So the providers see on a very close scale what's going on surrounding these measures, and they're comparing themselves just to other people who are working on the the same measures. Along the right-hand side, we have a description of the measures. The providers really like to know to the T what is going on in the measures they're being evaluated in, so all of that information is there. Generally, when we're at the practice, we go through this dashboard on paper, but we can also email it to them, and in the electronic version, if they click on the blue name of the measure, it's a hyperlink to a wiki page that shows them how to fulfill that measure in the EHR, so they know exactly what they need to do. And so here's an example of that. In this example, it's for cholesterol screening, and there's a CDS alert that's popped up, and the provider knows where they need to click in order to take care of that measure. And they also see what it should look like in the note once they've complied with the measure. So that brings us back to our public health functions, and we are hoping to gain additional access to various data sources to better assess the health of our community, and we're going to be disseminating this information to our providers so that they can improve their quality of care and we can assure a high standard of care. We'd also like to look at the cost impact of our work in the future, and hopefully we'll be able to use all of these results and this process to forge new partnerships with other organizations, and that will help us sustain ourselves as a regional extension center. So we have some lessons learned. The first is that being concrete about the things that you can offer and the goals that you have with a partner is really important. It makes writing a proposal easier. It makes understanding that proposal a lot easier, and it can really facilitate that movement towards a partnership. Out in the field, we've found that there's a huge variation in where each practice and provider is, and so you need to be prepared that there will be some basics that have to happen before you can actually work on quality improvement. There's a lot of simple things that need to be covered and cleared up before real work, the big work, can begin. And also, it's good to be prepared for resistance. We find in a lot of cases, providers are in fact doing all of the stuff that we want them to be doing as high-quality doctors, but they're maybe just not documenting it in the way that lets the EHR know that they're doing it, and that's really frustrating for them. So we went as far, a couple weeks ago as having one provider who just was outraged and frustrated that we were in his office asking him to do things differently and was complaining that EHRs were against human nature. So you need to have that understanding that change is not easy for them. Okay, and that's all. Thank you very much for listening. If you have any questions or comments or would like some further discussion, please feel free to reach out to any of us. Thank you very much.